Good evening, everybody. Thank you so much for joining me tonight on YouTube Live. I'm Dr. Howard Elkin, the medical advocate, and I have a really exciting program for you tonight because we're going to focus on cutting edge technologies for heart disease. So hopefully these things that you not familiar with, but you'll be hearing a lot about in the near future. Now, why do we need new technologies? Don't we have a lot of testing already? And we do. But let me just remind you the significance or prevalence of heart disease in this country. Heart disease is still the number one killer of both men, women, and all ethnic groups living in the United States. It's an equal opportunity killer. About 695,000, that's almost 700,000 deaths take place yearly in the United States. That's 1 out of 5 people, okay? And coronary disease is the most common form of heart disease that we see. And someone dies of heart disease like every 33 minutes. That statistic always, it's in my mind, the prevalence of this disorder, this disease. Now, it's not just an old person's disease. I mean, the average heart attack in a male is probably about age 65 and later for a female. But 2 out of 10 deaths take place in adults under the age of 60 years old. So it's not just a disease of elderly people. Now, 805,000 patients develop a myocardial infarction or a heart attack every year in the United States. 605,000 of those are the first heart attack, and about 200,000 is the second or third heart attack. And also, we need to keep in mind is about 45% of heart attacks are silent, meaning that there really are no symptoms to speak of. And that's especially true in the diabetic population. That's why I'm so bullish about testing my patients, doing stress testing and so forth, because my aim is not to allow any heart attack to go silent. That's kind of one of my missions. Now, what about women? Okay, this is always confusing. Over 60 million women, which is 44% in the United States, are living with heart disease. And heart disease is the leading cause of death in women, as it is with men. In 2021, it accounted for over almost 311,000 patients. That's 1 in 5 deaths, again, just like men. Now, death from breast cancer, let's talk about that. It's usually 42,000 women die every year from breast cancer, as opposed to 310,000 deaths from heart disease. And what is so surprising to me in this day and age, that only about 54% of women in this country actually realize that heart disease is their main killer, their main problem. They still center on cancer, but heart disease and death from heart disease in women is actually more common than all cancers combined. Now, I usually do this as a quiz. I'm giving a talk, but I can't really ask a question because I can't really address the people in the audience. But let's take an average 40-year-old. Can you imagine how many men, that 40-year-old men actually have a heart attack in their lifetime? The answer, 1 out of 2. What about women? The average 40-year-old woman, and the answer is 1 out of 3. So breast cancer, 1 out of 8 in women. So these are the important figures to keep in mind about the prevalence of the disease and the fact that the numbers really aren't coming down, despite all the technology. And I don't discount any of the advancements in both cardiac care, diagnosis, and treatment over the last several decades, because we've made a lot of progress, but we still have a long ways to go. So now, let's look at patients. What do doctors usually treat? Doctors usually treat numbers, right? What's your blood pressure? What's your HDL? What's your LDL? What's your triglycerides? It's always about numbers, numbers, numbers. And I'm a little different. It's not that I discount numbers, but I'm really interested in your risk. What is your risk of a heart attack or a stroke? And that's what I use to guide me in my recommendations with regard to therapy, is your risk, not just your numbers. If you're low risk, I don't really care how your cholesterol is. But so that's important to keep in mind. That's the difference between integrative functional medicine doctor versus your standard cardiologist. So those of you that know me know that I use Cleveland Heart and Boston Heart, which are specialty. I call them the Mercedes-Benz of cardiac testing, because not only do we look at particle number and particle size, we also do an inflammatory profile, metabolic profile, and a genetic profile. So we get a lot of information about the patient that helps me determine where to go, what decisions to make. Then we do scans. Besides stress testing, we also do coronary artery calcium scans, which generally detect calcifications in the coronary artery. So it gives me an idea. And the ideal number is 0. Right? You don't want to have any calcium in your arteries, but as we get older, that's not really the usual thing. So usually levels of 1 to 100 are mild disease, 1 to 400 are moderate, and anything over 400 is severe. But again, it's only looking at the calcifications. It's not looking at soft plaque. And there's another test that I use. We used to call it the pulse test, PULS, but now it's been switched over to something called Smart Vascular DX. And that looks at various biomarkers in your endothelium. Now, your endothelium is a very interesting cell. It's a true cell. It's a semi-permeable cell. It lines all 60,000 miles of your blood vessels. That's right, 60,000 miles. So as long as you have an intact endothelium, it's LDL cholesterol and other toxic elements are less likely to get into the endothelium and cause plaque. It always starts off with endothelial dysfunction, and that's when LDL gets in there and causes plaque, and then the whole cascade begins. So that's the testing that we currently have. And, I do, that's really advanced testing. Your average cardiologist is not doing that kind of testing. They're oftentimes just waiting for you to have symptoms. But we want and deserve more in 2023. And now that these two technologies I'm going to discuss are available, it's a very exciting time, because the interest that I have is transforming cardiac care as we know it. We can do better. We deserve to do better. And that's what I hope to show you now. So we want to make an early diagnosis with informed consent, and we want to do personalized treatment or precision treatment for the individual patient and tracking. So let's talk about the CLEERLY scan. That is CLEERLY. I don't know what it stands for, but it's CLEERLY. And that combines CT angiography, which is with a peripheral IV, looking at your coronary artery tree, along with artificial intelligence, which is mind-boggling to me. So these are FDA-cleared algorithms that we're using to non-invasively study plaque volume, plaque morphology, and it uses standard. We've been doing CT angiography for a while now, but when you combine it with artificial intelligence, you get phenomenal photos, phenomenal measurements. And unfortunately, until I learn how to share my screen, I can't really show you that, but I'll learn that next year. So we end up getting a 3-dimensional view of what your coronaries look like in great detail. And so we can look at the lumen, which is the space between the walls of the artery that blood flows. And we look at the vessel walls. How thick of it. And we can locate and quantify blockages, which we call stenoses. Most important, we can categorize plaque. Now, with coronary artery calcium scans, all we could detect is calcific plaque. Calcium, because it's hard. It won't show us soft plaque. But that was the problem with that technique, is that most of the plaque is soft plaque and we can't visualize it until now. So with CLEERLY scan, we can not only visualize soft plaque, we can categorize it. So there's calcific plaque, there is soft plaque, and there's something called low density soft plaque. That's the most dangerous. The low density soft plaque is a plaque that's really ready to rupture and to have a cardiac event. Now, just imagine if we knew that before a person has a heart attack, but you can with the CLEERLY scan. So it's looking at plaque morphology, the way it looks, and the images are pretty amazing, and you get a percentage of everything. It's just phenomenal. So now, this is grounded in science, and it's FDA approved to evaluate plaque. And so far, I think they've studied like something over 10 million images from over 40,000 patients over a 15-year period. So CLEERLY may sound new to you, but it's been studied. The artificial intelligence combined with CT angiography is pretty phenomenal. So then you have when you get a report, you'll get, it's a staging system. So it's like mild, moderate, or severe plaque, or of course no plaque at all. And that's what we get from the end result. So, and the real cool part about this test is that we can actually track your plaque, because we can do sequential studies. Let's say a year or two from one another. I mean, it is exposing you to radiation, so you wouldn't do them, but so often. But we have a baseline study which tells us the plaque burden, and if you have how much soft plaque, how much hard plaque, and how much of the dangerous low density plaque do you have, and then we can sequentially study that in subsequent studies. So it's really pretty amazing. So the purpose of this whole thing is to identify patients that are at risk before they develop symptoms, before they have a heart attack or a stroke. And that's the beauty of the CLEERLY scan. And there are a lot of work involved with this right now. And it's thought that it may eventually, could be actually surpass traditional stress testing. Because of the information we glean from this. And I'll give you an example. I have a patient, 65 years old. If you looked at him, this guy looks perfectly healthy. He looks younger than 65. Maybe he looks like early 50s. He's in good shape. But he had one of the most significant coronary artery calcium scans I've seen in my entire career. Like, there was like 3,500. That's really high, right? If anything over 400 is high, he's got 3,500. But that just tells me of calcific plaque. So then I did a nuclear stress test. Now, a nuclear stress test was done about 3 months ago on the guy, and he had no symptoms, and he had no evidence of being in jeopardy. His heart muscle was getting adequate blood, or so we thought. Then we did the CLEERLY scan a couple of weeks ago, and it shows some significant areas with the low density soft plaque. Dangerous, which means this could basically rupture anytime now, and he would have a blood clot and develop a full-blown heart attack. So I plan on studying him with a cardiac catheterization, despite the fact that he has no symptoms, despite the fact that the nuclear stress test was negative, because this is new information that we've gotten from the CLEERLY scan. Very exciting. So it's a new time in cardiology, and is it readily available? It is readily available. It's about ready for prime time, and I'm hoping that I don't know much about the reimbursement because it's relatively new. I'm just starting to use it myself, but I've been following this particular technique for a couple of years now. So I'm just glad that I found a place. I go to Harbor UCLA, which has done all my cardiac calcium scans the last many years, and now I can do the CLEERLY with it. So I'm really looking forward to an association with these people, and so I can learn more and help more people and before they develop heart attacks and strokes. This is really the crux of the matter. So let's switch gear to something called CARDIA X, CARDIA X. That's a new lab test, and it's by a company called Vibrant America. Actually, they have a new division called Vibrant Wellness, and they're located in the Bay Area. And what it does, it determines risk for both acute and chronic cardiovascular disease. And so why, again, is the information significant? Do we need more lab tests? Well, yeah, because it's nice to know your genome. Like where do you know if you're going if you don't know where you've been? And this tells us what you have. And so despite all the advances the last 4 or 5 decades, we still have people are dying, as I told you at the beginning of this talk. And, it's pretty obvious in this day and age that we need more than traditional cardiology. I'm known as an integrative cardiologist, which means I kind of look outside the box and do whatever is necessary for my patients, practicing functional medicine. That is not the majority of people in my profession. So a functional medicine approach is like, I'm looking for the hows and the whys. The hows and the whys. Like in traditional medicine, it's okay, symptoms, treatment. In functional medicine, it's symptoms, cause, and then treatment. That's the difference. We're actually looking for a cause. And I talk about this in my book. You guys know about my book. Somewhere here. I'll show you at the end. But it's how I practice medicine and have for many years, and try to get to the crux of the matter, because new risk factors are emerging. And it's not just like the 6 major risk factors for heart disease. We all know it, right? High blood pressure, smoking, high cholesterol, diabetes, obesity, and physical inactivity. Okay, and then there's a whole host of secondary risk factors that are listed in my book. But more important than that, there's a few new ones. I think we're beginning to really appreciate heavy metals, certain infections that can involve the heart, even things like chronic Epstein-Barr virus, long COVID, and then just a lot of really and like high ferritin. Just new things are emerging that there's more than just the primary risk factors that can lead to heart disease. So really, the cardiologists of today should be using a functional approach, and they need to know about metabolic disease. I mean, 5% of this nation is metabolically healthy. That means 95% are not. And that's, but don't take my word for it. What do you see walking outside? What do you see in Ralph's and Vaughn's? You see a bunch of obese people, and they're eating crap. They're eating garbage. So we have our work cut out for us. Now, so with this CARDIA X, there's like 23, 25 different genes that are being studied. And, and we're using genetic information to make health decisions. So, I said in my book, well, treating high blood pressure is just like, it's trial and error, right? So that's how it's been, because we have no guidelines, but now we will have guidelines depending on some of these genetic things. We will learn, for example, what gene can lead to what, and I'll tell you that in a minute. So, and to me, knowledge is power. The more knowledge we have about our genome, the more we can actually intervene and make changes with regard to things like diet, with regard to supplementation, and even certain pharmaceuticals. And I'll explain that in a minute. So who should be tested? Not everybody's going to want to be tested. First of all, this is so far a cash test, okay? It's about I think it's about $300, maybe up to $340. It's a lot of information, but you have to pay cash for it. It's not covered by insurance, and it probably never will be covered by insurance, because a lot of functional medicine testing is not covered. That's all. It's it. And your health is your wealth, so I think it's important to do this, but not everybody will. But who should get tested? That's the important thing. And family history. If you have family history of heart disease, it behooves you to find out your genetics, not just for you, but for your children, your offspring. What about if you have an unknown family history? I have several patients that they're adopted. They don't know their family history. So this is a great idea to learn that. And then if people that have uncontrolled symptoms, or we're not getting the blood pressure down, we're not really able to get their lipids down, the numbers aren't coming down like we should, and we have them on 2 or 3 medicines. I don't like patients being on 2 or 3 medicines for one problem. So this will be the perfect test to see, okay, what medicines are not really geared for this patient and which ones are based on genetic information. So there's really 4 categories that this test looking at. Hypertension, which is really, you got to remember that over 50% of the population in this country is hypertensive. So it's a big amount of people. Then we have lipid abnormalities, high cholesterol, low HDL, high LDL, low dense, large buoyant. So it tells us the family history of that, because probably about 20 and 30% of small dense, which is the unfavorable LDL, is probably genetically determined. So how do you know that? Well, you don't know that unless you do this test. Also, there's advanced predictive markers and detoxification methylation. There's a lot. So let me give you an example. I just wrote these out. I hope you can see this. So this is CYP1A2. What is that? That is a gene looking for patients that are sensitive to caffeine, catecholamines, which is like norepinephrine, epinephrine, and hypertension and inflammation. So that's kind of one thing. Then we have other genes that will help us out with determining hypertension. But here's the important thing. We will find out through this genetic testing what genes are good for what condition. For example, everybody wants to know, what's this thing about the controversy of low sodium diets? Now, cardiologists have been preaching low sodium diets for as long as I've been a student. And that's a long, long time. But most people really aren't salt retainers. And now we can figure out, we know by your genetic information, are you a salt retainer? Yes. Do you react strongly to caffeine? Maybe, and then this will help determine what we should do, how we should run our lives. So there's another gene that doctor tells us, will angiotensin receptor blockers be good for you? Will beta blockers be good? So it's really like, for example, if you have high catecholamines and your catecholamines are high, epinephrine, norepinephrine, beta blockers may be a good choice. So it's taking some of the guesswork out of medicine and treatment based on genetic information. Same thing with lipids. So we have one of the ones I talk about is ApoE. ApoE, and I test that on all my patients, looks at lipids, lipid analysis, and a statin response. People that are ApoE don't respond as well to statins as people that are not ApoE. And ApoE, actually, these patients tend to absorb more cholesterol than actually produce it. So we need treatment that will help to decrease the absorption of cholesterol from the gut. And we have it. We have a medicine called Zetia or Zetamide, and also artichoke extract can be very useful for that. So it's nice to know if you have ApoE, statins may not be the standalone. And what did most doctors put patients on with high cholesterol? Statins. And that's how they were taught from the pharmaceutical company. So again, it adds some knowledge that we need. Also, it's a marker for Alzheimer's disease. And if you have APO, there's two alleles one from one parent from another. So if you have APO3, that's the ideal one to have. If you have 3-4, if you have 4 at all, 4 increases your chance of developing Alzheimer's by like 20% or so. And if you have 2-4, it's APO4, that's like the worst, and that can increase your chance of Alzheimer's by, I think, up to 70%. Genes are not your end-all, be-all, but it does give us an idea what's going on so that we can initiate healthy living to decrease our risk of developing Alzheimer's disease or cholesterol problems. Another one that I've been using for a long time with Cleveland Heart and Boston Heart is 9p21. It's on the 9th chromosome. And that is predictive of heart attack, plaque rupture, intracranial aneurysm, so all these bad things. And so that's another one. That one is 4q25, which if you have a predilection, develop atrial fibrillation, which is the most common arrhythmia in people over the age of 70. However, I've seen it in people of all ages. Two of my closest friends had to have an ablation in their early 50s because of refractory atrial fibrillation, and I had a 29-year-old athlete a couple years ago that had to have an ablation. So it really hits all age groups. Then the detoxification and methylation. You've heard of MTHFR. I think I wrote that down here. One of my favorites. I guess I didn't. No, I just did. MTHFR. I know what it looks like, but it's not. Methyl tetrahydrofolate reductase. It's an enzyme. So I do that in most of my patients. About 60% of us have 1 or 2 copies. So it's not really what I would call a genetic defect. It's kind of like a typo. And what happens, patients that are MTHFR, 1 or 2 copies, they could be prone to high homocysteine levels. Homocysteine is a risk factor for heart disease, and you can easily treat it with B-complex methylated vitamins. So again, it's nice to know this stuff. I'd like to talk about 9p21 because we call that the heart attack gene. And you can have homozygous or heterozygous. Heterozygous is if you just have 1 copy versus 2. So if you have 1 copy, it increases your chance of heart disease and heart attacks by as much as 50%. If you have both copies, it can increase it by 80 to 100%. So it sounds really pretty scary, but again, what we do with this information is what really matters. So what we're doing, we're detecting problems before they happen. We're working on risk factors. We can eliminate as many sources of inflammation as possible: infections, environment, toxins, poor sleep, and excessive stress. And then we like an anti-inflammatory diet, which is basically anything that's not processed, a lot of plant-based and healthy food. And we limit carbs and starches. Another interesting one I'll talk about is CYP1A2. I don't know how these were named, but anyway. And this is the one gene responsible for caffeine metabolism in the liver. So if you're a fast metabolizer, you have a decreased risk of heart attack and high blood pressure. If you're a slow metabolizer, that means the liver can't clear it very well, and you can be very the caffeine hangs around for a while, you'd be very sensitive to the effects, and it can cause palpitations and dizziness and other things. So it's nice to know these answers. So again, you're taking genetics and applying it to risk factors, and also applying it to treatment. So it's nice to know that if I have this gene, I would do better with maybe less salt in my diet, or I have this gene, I may do better with more potassium and magnesium in my diet, or if I have this gene, I may do better on a beta blocker versus an ACE inhibitor. So we never had this information before. It was always like trial and error, but now we don't have to do that. Now we can take the information that we have genetically and build a therapeutic plan. But that said, I want to tell you one thing, and we'll end with this, is that your genes do not necessarily dictate your destiny, okay? I have patients say, oh, well, it's in the genes, so I guess I'm going to have a heart attack. If you really believe that, then you will. But genetics really determines about 30% of our clinical outcomes. 70% is lifestyle. So once we get this genetic information, we can say, okay, what can I personally do to improve my lifestyle so that I can suppress the bad genes and, and help and activate the good genes? And again, anti-inflammatory diet, exercise, sleep. You all know it. It's all the things I talk about in my book and when I see you in person. So it's an exciting time, and I'm glad to share these two modalities with you. And now we will open it up for questions. Thank you so much. Okay, my glasses on so I can read. Okay, doctor, I went last week to see my cardiologist, spoke with him, and didn't know about ApoB and a little Apo little a. What should I do? Find another cardiologist. If they don't know what ApoA is, or ApoE, or LP little a, this is bothersome to me, because these are not doctors are really in the 21st century. You have to know this information. And a lot of doctors don't want to even look at LP little a because there's no confirmed treatment for it. That said, I had a lot of luck with niacin. It's not responsive to diet or exercise. You can't will it away. It's just genetic. You have it or you don't. And about 27% of people in America have this particular this gene, this lipid abnormality. But they are working on something, and there'll be a biologic coming out in the next couple of years that can help lower Lp(a) by as much as 40% in as low as 5 or 6 weeks. So it's exciting. But your doctors know about this? I'm sorry. It's really important. You need to, in this day and age, you need to have a cardiologist that's familiar with metabolic health, as well as precision medicine. One size does not fit all. I've been saying this forever. And I won't stop. Okay, can you highlight the top difference between CLEERLY? Okay, I think I mentioned, but I want to make this very clear. The coronary artery calcium scan only detects calcium in your coronary arteries. That's it. And okay, you guys knew that I had a heart attack several years ago. I had a coronary artery calcium scan that was zero, about a year and a half before my event. And then I had an event, and it was more than likely soft plaque. In fact, I had another event in April. There's no way I could have survived a 3.5-hour back surgery in January 3rd if I would have had what I had in April. I was under extreme stress. I had a major event happen that I won't go into now. I talked about it a little bit in my last YouTube live. But I learned that despite doing all the great things that I do, like stress management and breathing, and I wasn't handling my stress mindfully on a daily, even minute-to-minute basis. I could not get rid of things like hostility and anger that I had to people that I thought didn't treat me well. And, you can't change people's opinions of you. So here I ended up with a heart attack again. But I had an ulcerated plaque. I had a soft plaque that ruptured. We could tell that at the time of angiography. So with CLEERLY, we could see hard plaque. And again, there's 3 different things. We're looking at hard calcific plaque, which you can get with a traditional calcium scan. Soft plaque, we've never been able to do that before. We've never been able to differentiate soft plaque or even to identify soft plaque with traditional radiographic techniques. And then the third one is this thing called low density soft plaque, which is the scary one. That's a plaque that can rupture and cause a heart attack. And then you have a blood clot, then you have a heart attack. So I want to make that clear. So really, we will now be able to tell the difference between heart plaque and soft plaque, and we can advise you. And the good thing about it, we can track your plaque over subsequent years to see what's happening. I'm getting my CLEERLY scan in the next few weeks as a baseline to see where I'm at because I want to know. Okay, Justin, I missed the first part and we'll watch it clearly. What is the cost of the CLEERLY scan? Okay, great news. So most insurances, definitely Medicare, and I think most PPOs will probably pay for a CT angio, which is cash for that is about $700. Okay, that's an angiogram with peripheral IV. They just, they stick an IV in your arm and they give you contrast, as opposed to the real deal, the gold standard, which they do an angiogram to the groin or the radial artery. So it's a lot less expensive, and it gives us a pretty good idea of what's going on. To add CLEERLY to it, it's just a few $100s more. I don't know. I was trying to hopefully get the figures, but some places will throw in the CLEERLY with the cost of the CT angio because we're just trying to get more experience with it. So stay tuned, and I'll be finding out more information about payment plan. So I don't know. You have to realize that CLEERLY is clearly it's FDA approved. It's not experimental. Although your insurance company will probably tell you that it is because that's how far behind they are. Keep in mind one thing: your insurance company doesn't give a damn about your health. Okay, now this could really help the insurance industry because we could be saving lives and promoting health, but they are basically penny wise and dollar foolish. They don't care that you're at risk of heart attack as long as you aren't insured with them, and that's how it is. So, but the cost will come down, but here's the thing about it: most insurances want you to just wait until you have symptoms. How smart is that? Or they don't want to do anything preventative. So it may be an uphill battle, and I, for one, am willing to work that uphill battle. Patients get studied because it would be nice to know what I had before I had it this last time around. Okay. Thank you. Oh, somebody read my book. Thank you. Okay, let's see. Yeah, I'm glad you asked your doctor for the calcium score, and hopefully he knew what it was. The calcium score test, that's about $190. Now, for some reason, Medicare covers that, but PPOs don't. It's about $190 at Harbor UCLA, and I think they did the best work. Okay. Any other questions? So again, the whole purpose of me introducing these, because I'm learning about them too, they really are new, is to really further our advancement into cardiac care. Like I said, we want to transform cardiac care. We're bringing it into the 22nd century, 21st century, because we want these numbers to improve. I don't want to be standing here a few years, or maybe my generation, or secondary people say, "Gosh, we haven't. The numbers look so much better." But we need early detection and identification and treatment, and that's the key, and that's why I think these will work. Okay, I'm just looking to did I miss any questions? Good. All right, if you guys do have questions, feel free to leave me a comment on this page. I will start looking at my YouTube page more readily now, because, and I know you don't always have questions during the presentation, but the presentation will remain here. Please share this with other people so you can spread the wealth, so to speak. And if you look at any of my videos on YouTube, please give me a thumbs up because that really does help my ratings. And please, 1 second. Don't forget my book, From Both Sides of the Table, and When Doctor Becomes Patient. Now, people ask me after that last cardiac event that I had in April, well, do you still think you're the medical advocate? I mean, you went through, you're living your book in reverse order. Before you had mild heart attack and back surgery. This year you had back surgery followed by a minor heart attack. And the answer is absolutely yes. I do feel like I am still a medical advocate because, number one, I made the right call this time. I didn't mess around. I thought what was happening. I dialed I dialed 911. And it's kind of weird when you're by yourself and your partner is no longer with you and you have to make the decision, but I did it. And number two, I survived, which makes me a winner. But number three, I came out with a message. I learned that not dealing with my stress in a mindful manner did not help. It hurt me. And I think that played a big role. So if I can inculcate that to others, then I've really done a good job. Okay, let's see. Did I do anything else? All my cardiologist did was run an EKG. I was hoping he would run other tests, but he didn't. Okay, I have had people have an EKG. They walk out and they have a heart attack. An EKG is basically a 6-second test. Does not tell you at all if you're at risk of a heart attack. It just tells you whether you've had a heart attack in most cases. It doesn't tell you if you're at risk. Again, we have to go way beyond the 20th century. We're in the 21st century now. We got to think in terms of how much we know, how much we could know, what we can do, and we want and deserve more. And that's kind of what I do. All right, guys, thank you. I think I got everything here. Thank you so much for joining me tonight. Come back. I'm trying. Next month, I think, is an important month. I don't know what I'm doing yet, but I'll have at least one, if not two, presentations. So please subscribe, and you will get notification. And get my book. You can get it on Amazon. My website is for the book itself is beyourownmedicaladvocate.com, and then you can go to my Amazon page and you can get the book. I think the Kindle version is $9.95 and the paperback is $18.95. And share with other people, because that's my whole thing, is to spread the wealth so that we get more people involved. Thank you so much, guys. Good evening, and again, thank you so much. Appreciate it.